Good afternoon, everybody. Thanks so much for joining me. This is one of my favorite topics, autism spectrum disorders. We're going to start with a little introduction into the CARD Center, who's sponsoring this talk today. So I'm going to read you their mission statement and vision. FAU CARD is the Center for Autism and Related Disabilities, provides expert consulting, training, and support at no charge for all people across all race, ethnic, and gender groups with autism and related disabilities, their families, employers, the professionals and community, and governmental agencies serving them. The vision of FAU CARD is to provide support and assistance with the goal of optimizing the potential of all people across all race, ethnic, and gender groups with autism and related disabilities. And these are the counties that CARD serves. You can see they have a very wide area, and they have offices in Boca, Jupiter, and Port St. Lucie. So this is a little introduction into myself. It's always a little awkward to see your own credentials in front of you. But I am a board-certified developmental and behavioral pediatrician, and that's someone with special expertise in children with neurodevelopmental disorders. Autism has been one of my passions, and I've been in practice since 1993. So I have lots of experience. I did my undergraduate at Dartmouth Medical School, at the University of Miami Miller School of Medicine, and I trained at Jackson Memorial Hospital. So I'm a local. So the title today is Autism Spectrum Disorders, What Teachers Need to Know. I will tell you with all sincerity, teachers are one of my favorite groups to present to. I think oftentimes you don't get to hear from physicians, and I think it's a worthwhile perspective to have. I'm hoping I'm going to be able to provide some of you who are already very familiar with autism spectrum disorders some new insights. And for those of you new to the field, I'm hoping I can give you a nice overview and bring home some practical things you can utilize in the classroom setting. So I really want to start with a definition, and I'm sorry this is a very wordy slide, but I think it's very valuable because it's very clear and non-judgmental in painting an accurate picture of what we mean when we talk about autism spectrum disorders. And of course, it's critical that we all have a common starting point. So I'm just going to read this to you all. Autism spectrum disorder, ASD, is a developmental disability that can cause significant social, communication, and behavioral challenges. There is often nothing about how people with ASD look that sets them apart from other people, but people with ASD may communicate, interact, behave, and learn in ways that are different from most other people. The learning, thinking, and problem-solving abilities of people with ASD can range from gifted to severely challenged. Some people with ASD need a lot of help in their daily lives, others need less. And that's a definition from the CDC, and I think it's actually quite elegant because it lays out all the different aspects of what constitutes the spectrum. So what happened to autism, Asperger's, PDD, NOS? Some of you may have been doing this long enough to remember those terms. Well, previous to the current active edition of the Diagnostic and Statistical Manual, which we call DSM-5, the diagnostic terminology was different. And the pervasive developmental disorders encompassed Asperger's, autism, PDD, NOS, Rett's, and childhood disintegrative disorder. Now, that was in DSM-4. Now we've replaced all of these, what are called the PDDs, with ASD, autism spectrum disorder. What that looks like is Rett's and childhood disintegrative disorder have been dropped from the grouping in the DSM-5, and ASD itself constitutes Asperger's, autism, and PDD, NOS. Those are now all rolled into one and no longer exist formally as diagnostic terms. The way we specify severity is through levels. So it's ASD level 1, 2, or 3, which essentially corresponds to mild, moderate, and severe. And the level is determined by the amount of support a child needs. So a child who needs very little support would be mild. A child who needs full, comprehensive one-on-one support would be a level 3. In addition, when a diagnosis is made, a clinician is supposed to specify not only the level, so level 1, 2, or 3, but also whether or not there is a language impairment and whether or not there is an intellectual disability. So those things should be specified in the diagnosis when it's made. Not always done, but if we're doing it by the book, that would be the case. Also, if there is a coexisting genetic or other developmental disorder, that should be specified. Now, very interesting with ASD now, in this new version of the DSM-5, is a child can have ASD and ADHD, ASD and generalized anxiety disorder, or OCD, depression, learning disabilities, etc. So up to 40% of the time, in fact, we see individuals on the autism spectrum have a coexisting, or what we call comorbid diagnosis. Previously, it was thought these things were subsumed under the ASD label. So this gives us a little more precision in diagnosis. And any individual previously diagnosed with any of the pervasive developmental disorders would automatically meet criteria for ASD. So this is a lovely slide because it gives you a nice visual of what's different, what changed. So in the DSM-4, we had three, well, I was going to make my little circles here, 3 different groups we had of impairment. So the social impairment was separated out from the speech and communication delay, and then the repetitive behaviors and restricted interests is that third red circle. Well, what's happened now in DSM-5, if you look at the right-hand side of the screen, is the social and communication disorders have characteristics have been collapsed into one. They've been combined. So we have a social and communication deficit, which is considered one domain, and then the restricted and repetitive behaviors and interests. That's just a little picture to give you a visual of what that giant DSM looks like. So this is another wordy slide. We're not going to go through every line of it. You can go back and refer to it if you're interested, but I wanted to point out the differences between DSM-4 and DSM-5. So, like I said, the social and communication. So if you look at the left-hand side of your slide, you see there's 4 enumerated 4 social behaviors and 4 communication behaviors. That's now been collapsed and condensed. And now we have social and communication deficits where an individual needs to meet all 3. So this is interesting because if you look at DSM-4, it was like a menu, and you had to have 2 of 4 of the social, 1 of 4 on the communication side to meet criteria for that first level of impairment. Well, now you have to have all 3 of 3. So those are deficits in social and emotional reciprocity, deficits in nonverbal communicative behaviors used for social interaction, and deficits in developing and maintaining relationships appropriate to peer level. Another very interesting feature is, if you look at what's highlighted in yellow there, is this is characteristics that are currently present or by history. So if the child has made tremendous progress, but is coming to a diagnosis late and isn't currently displaying all of these characteristics, but had them in the past, they could still qualify for a diagnosis. And then the second part, the restricted and repetitive behaviors and interests, right? We have the social and communication, then the RBIs. Well, here there's a lot of similarity. What's new, and you'll notice you have to have 2 of 4. So this is where a child doesn't have all the characteristics to meet criteria for the diagnosis, but you need to have 2 of 4. And if you look at the right-hand side in the DSM-5, what is new and long overdue is number 4, which is the hyper and hyporeactivity to sensory input, or unusual interest in the sensory aspects of the environment. This was actually partly embedded in some of the prior descriptions, but pulled out as its own category, many people feel is very important because so many of the kids on the spectrum have sensory issues. And then of course the others you're well aware of. Number 1 is stereotyped or repetitive speech, which would be echolalia, motor movements, which would be flapping, etc., or spinning objects, repetitive behaviors. Number 2, insistence on sameness and flexibility, getting stuck, meeting routines just so. And then the third, those highly restricted and fixated interests. So boiled down, let's simplify it. New criteria, ASD in the DSM-5, 3 of 3, social and communication. So you have to have problems with your reciprocity, your gestural or nonverbal communication. And that includes a lot more than eye contact. That's eye contact, that's gestures, that's affect, that's facial expressions. And then the third is peer relationships appropriate developmental level. So those all 3 of 3, and then 2 of the 4 criteria in the RRBIs. And then of course, to be a true disorder and not just someone who's atypical or quirky, there has to be significant impairment, multiple settings, right? And now the diagnosis can be made virtually at any age, but we'll talk a little bit about that. Obviously not in the super young. So improvements in DSM-5, well, inclusion of the sensory difficulties, support of late diagnosis has been really helpful. Some individuals have incredible compensatory mechanisms. In girls, they use the term camouflaging or social mimicry, where they just slide under the radar. And sometimes these kids don't come to be identified until things really fall apart. And one of the things that can lead to that is increased social demands. So for example, I've had many patients who did extremely well through elementary school, get to middle school, and social becomes much more complicated and they start having a lot of difficulties. So previously symptoms had to be present before the age of 3. That is no longer the case. So symptoms can present at later ages. And very important improvement is the behaviors don't need to be directly observed. So if they're there by history, well documented, that's sufficient. Another improvement in the DSM-5 is the end of PDD-NOS and Asperger's. Now people could debate that. PDD-NOS tended to be a very broad, sort of euphemistic diagnostic label that people threw around without a lot of precision. So I think a lot of people are glad to see that go. As far as Asperger's, some people lament the loss of Asperger's because affectionately known as Aspies, individuals themselves on the Asperger's, having Asperger's like that label. And maybe it's something that's missed by clinicians as well as some individuals on the spectrum themselves. But people are getting used to now just the concept of the spectrum. The other thing I pointed out earlier about coexisting or comorbid diagnoses are now acceptable. They can be applied, and that leads to more precise diagnoses. And then, of course, just understanding and appreciating that ASD, autism, is a spectrum. So having that word embedded in the diagnosis, I think helps reinforce that. Now, what are some of the limitations? Well, there have been some studies that have shown in younger children, they can fail to meet criteria for ASD for a variety of reasons. The criteria are narrower despite the concept of a broad spectrum, and possibly as high as 1 in 5 children get left out. That's easy to understand if you go back and look at that DSM-4, where you had all those combinations, right? You had, 4 possibilities for social, 4 different possibilities for communication, and now it's just the 3 of 3. So that's yet to be firmly established, but there have been some studies that have showed some kids are being missed. Higher IQs may be less likely to get diagnosed. Over-reliance on the ADOS, that's the Autism Diagnostic Observation Schedule. With DSM-5, it's not the fault of the DSM-5, but just concurrent with that, there's been a big emphasis on use of the ADOS for diagnosis. I'll talk a little bit more about that later, but that can be problematic because it's a very lengthy and very expensive test to administer. Some of the general problems with the DSM are just the fact that there still is an overemphasis on labels and pathology and a very high level of well, not a very high, but a high level of subjectivity because it's through observation. And in general, the DSM just highlights deficits in pathology over all else. And many clinicians, including myself, like to come from more of a strengths-based perspective. Social and communication disorder. So that is a new diagnosis in DSM-5. Some of you may have heard of it. And social and communication disorder, this is individuals who have a marked social communication deficit, but their symptoms do not otherwise meet criteria for ASD. And this is because in SCD, so social communication disorder, they do not have any of the restricted and repetitive behaviors and interests. So if you think about it for a minute and you think about all those social communication deficits and what they look like, well, these are the SCD kids. They don't have any of the repetitive behavior. So they're not echolalic, they're not flapping, they're not rigid, they're not sensory. It's just the social and communication deficits. And in the past, I think the kids that would have fit in here are those that we call have a pragmatic language deficit, for example. But the problem with this diagnosis is it's not widely accepted. There are no specific diagnostic tools to make the diagnosis. I don't think some school systems even recognize the diagnosis. So it's a bit problematic. Treatment for kids with social communication disorder are just like treatment for children with pragmatic language deficits. It's mostly speech therapy and social skills. There has been a worry, this bullet point two, is this what we call an orphan diagnosis or possibly the new PDD-NOS in the past? When a clinician was very concerned about using the ASD label for whatever reason, including perhaps parent acceptance, they often mislabeled kids as PDD-NOS, which was very general. And I'm hoping things aren't going in this direction. Thus far, there isn't any research to show that's the case. But I'm not really sure where we're headed with this diagnosis. It does exist, though. And like I said, these are the kids with just the pure pragmatic language deficits. So what does an evidence-based medical assessment look like? So I'm going to get into some of the medical terminology now, which I hope not to bore you with too much, but I think it's nice for teachers once in a while to hear from people outside their field. So who can make an ASD diagnosis medically? A developmental behavioral pediatrician, which is my field, neurologist, psychiatrist, they're all credentialed in the medical field to make this diagnosis. I'm leaving out psychologists because I'm just talking medical now. So those are the three medical fields you would generally see a diagnosis made by one of these types of clinicians. We all know there's a big difference between a medical diagnosis versus eligibility for educational services. I've had patients where they have a medical diagnosis, but they're not eligible for services because for whatever reason, perhaps their level of function is so high that there isn't truly a need. So it's important to always keep that point in mind. So what does a medical assessment consist of? A comprehensive neurodevelopmental history, the past medical history and surgical history, family history, physical exam, observation of behavior, and a structured assessment tool specific to autism spectrum disorders. And I wrote there some of them. There's the CARS, the Childhood Autism Rating Scale, the GARS, Gilliam Autism Rating Scale, the ADOS, which I mentioned earlier, SRS, a Social Responsiveness Scale, and then the Autism Spectrum Rating Scale. Now, this is a super, super important piece because without a standardized assessment tool in the state of Florida, a child cannot receive ABA therapy services. That is a change. That is something different. In the past, a clinician could make a clinical diagnosis or just say a child meets criteria based on their expertise and descriptions of behavior, but you got to have more. In addition, a thorough evidence-based medical assessment does have at least some type of screening assessment of language, cognition, motor skills, adaptive behavior, and self-help skills, and social emotional functioning. EEG, MRI, genetics are only if indicated. Not every child on the spectrum gets those examinations performed. Hearing and vision, always, that's a must. Other conditions need to be ruled out. And then extremely helpful always is what we call natural setting observation and rating scales completed by others, in particular teachers. I so value teachers' input. So they can have a role to play sometimes in an evidence-based medical assessment. And then, of course, the clinician themselves need to do a very detailed descriptions of behavior through observation or history. Here's a little medical slide for you about what are the actual differences we see in the brain. And there's a lot. There's a lot of different things. Autism is what we call a very heterogeneous disorder. There isn't any one pattern, any one thing. In general, though, generally speaking, many kids on the spectrum have larger brains. Certain structures, such as the amygdala and the corpus callosum, tend to be a little smaller. There's something called pruning of neurons, which isn't done to the same degree as in typically developing children. Some of the connections in the brain are different. There's fewer long range, more short range connections. Some of this leads to things we see, such as a preference for geometric patterns over faces, a preference for seeing details over the big picture. A couple of positives I think that are important to highlight is that they can have a superior ability to spot patterns and a superior ability to systematize. And this goes back again to that concept of strengths. We don't want to just look at deficits. There have been fMRI studies of individuals doing problem-solving tasks, and there have been some efficiencies in cerebral functioning in individuals on the spectrum, which are notable, and certainly areas that are being more further explored. And there is a hypersensitivity of the auditory cortex, and that makes sense, right? With the sensory sensitivity to sound, that's very common in individuals on the spectrum. So I like that quote at the end, there is not one way to be normal, right? We all know that. And we'll get into later a little bit about the concept of neurodiversity, which is similar to biodiversity. So let's get into some of the things you might see, things that are a little more specific to everyday observations by teachers in the classroom. So here's a little guy, young guy, lining up his toys. And then I also want to include a little girl because females are still missed. So even though it appears it's a 3-to-1 ratio male to female diagnosis, I don't know if that's really the case or if we're just missing a lot of girls. So at the preschool level, what can you see? These are things I'm sure most of you are familiar with, but not responding to name, a lack of that back and forth play, which we call joint attention, limited pointing. Language can be completely delayed, echolalic, or there can just be jargoning. Repetitive and non-purposeful play, so just dumping toys, lining up toys, stacking, instead of creative and imaginative use of objects. Eye contact can be limited or absent completely. Repetitive body movements, posturing, different hand flapping, finger flicking, spinning, rocking movements, all done though to an excessive degree. Difficulty redirecting. So these are kids that have an intense fixation on what's in front of them or what interests them. And we call it, sometimes we call it sticky attention, which I think is a great phrase, or a preference for things over people. Unable to engage in expected activities for age. A lot of difficulty with transitions, right? As teachers, you know about all that. Just extreme upset if the routine or a transition happens that they're not ready for. And then the rigidity and flexibility, sometimes severe tantrums. And another behavior that we can see sometimes is just inspecting things from unusual angles, looking at their side or from the bottom. This is a picture of the family depicted in the fictional show Atypical. Some of you may be familiar with, which is about an individual, the boy in the middle on the spectrum. And so things look different, right? In older kids, things are going to look a bit different. In older children and in teens. So the difficulty making and keeping friends may be a primary problem working in groups, trouble changing topics or staying too long on a topic, that kid that just talks about the same thing or doesn't know when to give it up. Missing social cues, eye contact once again can be intermittent or atypical. Hygiene can be a big issue. This comes up a lot in the middle and the high school kids with brushing their hair, wearing deodorant, clean clothing. This group, easy target for bullies. Sometimes kids come to attention once there's been a consistent pattern of bullying. Inflexibility, and then all those executive functioning deficits you're very familiar with, the planning, organizing, doing what is asked. Those are pretty typical of many individuals on the spectrum. Still, motor mannerisms can be present. They can be more disguised. They can still sometimes be flagrant. Relating better to staff than peers. That's a big tip-off, big red flag. And once again, problems with the transitions, sensory sensitivities, and then abnormalities in language, some of which are listed there. So globally, in general, what do all those big lists boil down to? Well, if you have a child in your classroom and they have a language or speech problem, ASD always needs to be ruled out. You're worried about their play skills, their socialization, got to rule it out. If you get this history from the parent that they're consistently not sleeping, or you see in your classroom they're very unusual or extremely picky in how they eat, all those sensory sensitivities we mentioned, that need for sameness, problems transitioning, and then all those externalizing behaviors we talked about, tantruming, rage, sometimes defiance, eloping, very big, especially in the younger age group. Frequently off topic or out of context statements. The kid who raises their hand and is talking about Navajo Indians and you're in math class, for example. Very unusual interests or fixations, being disorganized, and just general problems with motor planning that can be handwriting, zipping, unzipping your backpack, getting your papers and binders together, all that kind of stuff. So what are some special considerations in diagnosis? Well, it's tough in little kids. So that's my population, toddlers, especially toddlers with language disorders or that are super hyperactive and impulsive and ADHD type symptoms, children that have been victims of neglect, kids that are on screens all the time, and kids with delays and milestones. Sometimes those things create some challenges in separating out what may mimic an ASD and is a true ASD. I want to point out the screen time there. This is something that I've been seeing more and more of, and especially during COVID-19, it's become even more dramatic. There is regression. We can see regression, and especially in young kids. I've had young kids who come in, and I call it acquired ASD. They look terrible. They have no eye contact. They're not reciprocal. They're not creative. They can't play. They're fixated. We get rid of the screens and a lot of things improve. So I just wanted to point that out. It's very important. We always think about delayed development versus atypical development, right? Not everything that's delayed is atypical. When we're talking about ASD, we're talking about atypical development. There is no single objective medical test for ASD yet at all. So it's a combination of the history, observation, and the ASD specific rating scales. It is still a clinical diagnosis through observation and history that we make it. ASD can be diagnosed as young as 15 to 18 months of age by an expert clinician. The ADOS Autism Diagnostic Observation Schedule I mentioned earlier has a toddler module. So I have diagnosed kids as young as 15 months. After 3, diagnosis is more stable, right? I've had those kids borderline. We diagnose them young. They're on screens all the time. They get a lot of therapy, and they seem to do so well that sometimes we actually remove the diagnosis. It's unclear in those kids whether they really were just optimal outcome children that did really well, or perhaps we were a bit on the side of overdiagnosis. The average age of a diagnosis in the United States is still too old, 4 years of age, when we could be catching them much younger. And for minority children, a later age of identification and diagnosis is still a significant issue. As I mentioned earlier, frequently overlooked. Well, here I put male, female is 4 to 1, but it's overlooked often in girls. And an IQ over 70 is quite common. More and more studies are showing that to be the case, and many can be gifted. Risk factors and causes. So some of the risk factors we know of are advanced maternal or paternal age, a family history. So there's a 25% increased risk in a sibling. Identical twins, highly concordant. So if one twin has it and they're identical, there's a 77 to 80% chance the other will. Prematurity is an independent risk factor. So we see more ASD in kids who are born premature. A shortened interpregnancy interval seems to be a risk factor. And then we have certain genetic syndromes, right? Everybody knows about Fragile X, tuberous sclerosis complex, Rett's, higher likelihood of autism spectrum disorder in these kids. And then there are specific genes. CMA stands for chromosomal microarray. CNV is copy number variants. So these are highly sophisticated genetic tests. And in about 10% of individuals with ASD, we will find something. And overall, about 20% of cases of ASD, a genetic cause is identified of some type. These are expensive tests, sophisticated tests, not always done, but there are certain times they can be very helpful. And G times X, that means genes and environment. So we don't know what's causing these genetic disruptions still, right? We don't know if it's an interplay or if it's a spontaneous mutation, likely a combination of all the above. If you're really interested in genetics, a lovely video on YouTube by Dr. Chung. I think she's out of Duke. Excellent, has some of the latest information. And then in terms of environmental, infectious, and drug-induced factors with the spectrum, I'd like to refer you to the University of California, Davis, where they have something called the Marbles Project, which is looking at these environmental factors. So listed here are a lot of the different theories, and there are many. And unfortunately, or maybe fortunately, right? As I said earlier, it's a heterogeneous condition. So there are likely many different causes, many different pathways to autism, not just one. The more we learn, the more complicated it becomes. All right, 2020 has not been a good year. Not to say that having more autism is not a good thing, because I don't want to insult some individuals on the spectrum who have been able to achieve wonderful things with their spectrumness, but incidence went up again. So we went up another 10%, from 1 in 68 to 1 in 59. Now, why is this? What's going on? This is always the question, and I'm not going to be able to answer it completely, but let's delve a little deeper into some of the points about prevalence. So the Autism and Developmental Disabilities Monitoring Network, that's that ADDM, that previous slide I showed you, the 1 in 59. This is a CDC longitudinal study that's been around for almost 25 years and tends to be pretty accurate. So I would bet on those numbers, being truthful. Now, more kids are being identified, more at younger ages. So if we're picking them up earlier, that's going to add to the pool. There's also an increased awareness, increased training of clinicians, the public, teachers like yourselves. All these things drive up cases. Some other things that drive up cases that maybe are more confounds, including needing a diagnosis to get services. That can drive up the numbers. Something which we call diagnostic substitution, which is where a clinician is substituting one diagnosis for another. I'm not going to say that's a standard that's done all the time, and it's clearly not ethical to do that diagnostic substitution, but it has been done. So I just want to mention it. So for example, instead of intellectual impairment, a child's diagnosed on the spectrum, perhaps they have both, but you know, that gets into a thorny area of, once again, using a diagnosis to drive services. I actually think we're seeing less of that now. And then of course, like I said, there's most likely a true increase. And the broad criteria, all these things play a role in prevalence. The gaps I mentioned earlier, there are racial gaps. So Hispanic, Black, white, that's sort of from the least to the most diagnosed. Gender disparities. And of course, there are geographical issues with availability of a proper diagnosis as well as services. Just remember that ASD is worldwide. People tend to think we overdiagnose everything in America. Maybe we do, I don't know. But ASD is seen throughout the world. And it's important to remember that just of all children, right, between 3 and 17 years of age, about 70% will have some type of neurodevelopmental problem, which is a high number. Another wordy paragraph here. I apologize. This is the last wordy one, but once again, I think this is very important for us to look at. Let me just check our time here, make sure we're doing okay. Because treatment is an area where things get controversial. So I want to read this to you, and then we'll zoom a little quicker through some of the subsequent slides about treatment. So from the NIH, there is currently no one standard treatment for autism spectrum disorder. That might shock people just right there. Many people with ASD benefit from treatment no matter how old they are when they are diagnosed. People of all ages at all levels of ability can often improve after well-designed interventions. There are many ways to help minimize the symptoms and maximize the abilities. People who have ASD have the best chance of using all of their abilities and skills if they receive appropriate therapies and interventions. Because there can be overlap in symptoms between ASD and other disorders, such as ADHD, it's important that treatment focus on a person's specific needs rather than a diagnostic label. Touche, love that. So what does that mean? Treatment must be individualized, just like an IEP and medical treatment as well. Individualized treatment is the most effective. It needs to be target symptom focused. What are the problems for that particular child? Which behaviors, which skills? Do they have an affective problem? Which deficits? What are their strengths? What are their coexisting problems? All of these things get factored in. An eclectic approach is much more important than a specific therapy or treatment. So sometimes people adopt specific treatments almost like a religion, when really you have to draw from whatever you need and see what that child needs. The most common targets for medication are attention, anxiety, OCD, aggression, repetitive behaviors. We'll get more into that later. And coexisting medical conditions are important to be aware of. These kids are more prone to seizure disorders, GI problems, skin problems, and nutritional problems. So in a nutshell, effective treatment, it's comprehensive, it's multi-system, strengths-based, considers the family, the school, the social setting, the community, and it's collaborative. All right, what are some of those evidence-based treatments? Everybody knows about ABA, right? So about 20 to 40 hours combined interventions consisting of ABA, something called ESDM, the Early Start Denver model, extremely effective with young children, pivotal response training, the DIR model, which is also known as floor time. And there are other models that have research, that have evidence, but those are, I think, the primary ones that you'll hear of and that children in our community are partaking in. In addition, of course, speech therapy were indicated, occupational therapy for fine motor and sensory, physical therapy for some of the more of the gross motor and motor planning issues, social skills training, pragmatic language groups, all of these things are evidence-based and effective. You guys are the experts of the ESE supports, right? We know these kids need supports, variety of models out there. I mean, Teach, PECS, Social Stories, and others. So there are other therapies that are a little more marginal, but have some data, and that's hippotherapy, that's horses, sensory integration-based therapies, which are predominantly provided by occupational therapists. And as we'll get into more, medications used selectively, modified cognitive behavioral therapy, and art and music therapies. Older individuals, higher functioning individuals, involving them in their care and what they need is important. So let's get to medication. Medications are used to treat behavior, cognitive, social, emotional problems, not the core deficits of autism. There is nothing out there that treats core deficits. That's an exciting area of research. Things will come. People have talked about oxytocin for years, not ready for prime time. So to date, there is no autism medication. What there are medications to treat the coexisting problems. So like I said earlier, if you got ADHD, if you got OCD, if you got anxiety, if you have depression, some of these other things, we use the ADHD meds, some of which I'm sure you're aware of, the stimulants and non-stimulants. For the OCD, anxiety, depression, the SSRIs and SNRIs. And then severe aggression, we do have 2 medications FDA approved to be used in autism, and that's aripiprazole and risperidone, but they're being used to treat aggression and irritability, not specifically the autism itself. Mood stabilizers have been used with a lower degree of evidence to back them up. And there is a tendency, this try anything tendency, which we can see in autism, and it's a shame, but we can sometimes see a lot of polypharmacy, a lot of experimentation, which is problematic, of course. Principles of good medical practice. So good medical practice means you start with what's evidence-based, and you start with psychosocial treatments, which include parent training, behavior therapy, starting with therapies before medication. That's a general rule for good medical practice. That doesn't mean there isn't a case where it may be a severe disturbance of behavior, affect, cognition, and a child may need medication first. Parental involvement is essential, along with other caregivers, teachers, therapists. Everybody partnering together will lead to the best outcome. Teacher observations are critical. I send teacher rating scales all the time. Love it, super valuable. Sometimes it's the critical insight because you're spending more time with the kids. In mild cases, a course of at least 12 weeks of psychosocial interventions, like I mentioned, before considering medication is appropriate. I'm going to say that rule has been bended in COVID times because we can't get the psychosocial interventions kids need sometimes. So this is a rule that's flexible. Let me not even say rule, guideline. And like I mentioned, in moderate to severe cases, immediate use of medication may be appropriate, and treatment needs to be individualized, avoiding polypharmacy where possible. Doesn't mean every kid or any child who's on more than one medication is being improperly treated. Not the case. It's just we try to avoid polypharmacy, which is really more than 3 drugs whenever possible. First, do no harm. That is part of our code. That's part of our Hippocratic oath as physicians. And we always have to weigh risk versus benefit with any medication and make sure a medication we're using is practical. So that may be a dosing issue. 4 times a day medication, not practical, right? Let's talk quickly about diet. This is a brief one, huh? There's little evidence to support the use of nutritional supplements or dietary therapies for children with ASD. Well, and that's 2017. There have been big meta-analysis studies. Listen, it's hard to prove nutritional interventions work for most things, so ASD is no different. That doesn't mean it's entirely irrelevant. I think a good foundation of solid nutrition is important, but let's go through a little bit of this. And it's just important to know that there is no definitive proof about its effectiveness. Research in this area, of course, is difficult, right? Not only because of the variability of the population of children on the spectrum, but the length of time needed to study a dietary effect. Controlling for the impact of other interventions. No kid is just changing their diet. They're changing their diet. They're getting OT. They're getting ABA. They're getting other things. So it's very hard to have a controlled experiment and the sample size necessary. Nutritional information is constantly changing, right? For all of us. Should we eat plant-based? Cholesterol is not a problem anymore. It's really sugar. We need antioxidants. So it is an area that just in general can be confusing. There are a lot of limits to how much laboratory testing can guide dietary choices. Some of the allergy testing, for example, for foods is highly suspect and not always accurate. For foods, true food sensitivity and allergy, you need skin testing. In autism, we have the unique problem of sensory issues with food that can play a big role. So why are so many people drawn to it? Well, why are so many parents drawn to it in kids with autism? It's obvious, right? You can exercise control. You get to decide what a child eats, and there's value in that. There can be a big bias towards dietary changes. Many times people feel that they're less harmful than medications. Not always the case. I'll point really quickly to some studies of kids who are on gluten-free, casein-free diets and eating too much rice and then having elevated levels of arsenic because of arsenic levels in rice. So it's always cost benefit, right? And many times there are very, very, very strong beliefs in specific dietary approaches, and that's okay. As long as it's not harmful, you know, it's an area people want to exercise control. No one has all the truth on it. So I think it's fine as long as a child is being properly supplemented. Problem for teachers is sometimes kids come in on pretty funky diets and they want to eat the kids' cheese doodles next to them, and then they have a tantrum because all they have are, you know, bran sticks and I don't know, popcorn. But you got to do your best, right, to work with these families. We all do. Communication. Communication is interconnection, right? So I want to share with you in these final slides some of the lessons from medicine that we share as doctors and as teachers. So I think about communication in kind of these simple terms. There's one way, I'm telling you, it's all unidirectional. There's dialogue. In medicine now we call it shared decision making, and that's really how we like to think of medical management, involving the patient, addressing their concerns and their issues. Communication can be in person. Today, not so much, right? We say first person communication where we're talking about each other in the first person, not in the third person. Technology assisted, that's what we're all doing now, right? We're texting, we're Zooming, we're FaceTiming, whatever it takes so that we can communicate. Critical to me, and I think I share this big time with teachers, is time efficiency. Sometimes a parent, if it's by phone, it'll be 15 minutes before they even get to the point. So being mindful of time, of course, confidentiality and keeping communication as positive and empathetic as possible. Many times parents are upset. They're upset with their teachers, they're upset with their doctors, and we need to keep our cool best we can. So teachers, you guys are the experts. I say time equals expertise because you spend the most time with children, right? 4 to 6, that's hours per day. So a parent might spend anywhere from 4 to 6 hours with their kid. You spend 8 to 10. So you're spending more time with children Monday through Friday than their parents. You get to observe the social interactions, which parents are not privileged to see, right? So there's important value in your observation there. Going back to point 1, we'll talk about it a little bit at the end, but this whole online thing is turning bullet point number 1 on its head, and that's not escaping me, and we'll go back to that. You are often, teachers, the first to inform the parents of a concern. You're the first ones to see it and the first ones to bring it up. Also, you can play a critical role in inspiring children and families. And I hear this all the time when people just talk to me in glowing terms about their teachers. You can have a profound influence on a child's future and the general hope and well-being of a family at large. So it's important to be mindful of that. Now, from the perspective of a parent, they see everything through the unique needs of their child, right? They're not always great at looking at the big picture, what else is going on in the classroom. What they see at home sometimes can be very different from what's seen at school. And sometimes you just have to respect that that's truly the case and be open to what a parent wants to say about what that child is able to demonstrate they can do in the home setting. They experience the tail end of the emotional cost of the school day. Sometimes there can be big difficulties parents have in communicating with teachers, and this causes frustration. Goodness of fit, teacher, family, teacher, student, doctor, patient, all the same thing. And when we get into those situations, we just have to do the best we can to work with it. Parents are the ones who experience those homework nightmares. I mean, so many families I have where homework is the nidus of all of the conflict in the family. And, you know, that's just what they experience. The effects of bullying and peer interactions are going to be more acutely felt, of course, by parents. And of course, they're going to have a much broader awareness of all that child's sensory sensitivities. Yet we got to, you know, so I wish teachers could take parents' perspectives sometimes. And I really wish the parents could take the teacher's perspective sometimes. You know, class size, lack of staff, resources, curriculum, testing demands, lack of training in developmental disabilities, and yet having integrated classrooms. Sometimes the effects of individual accommodations on the class as a whole can be a problem, as well as disruptions to the schedule that a child who's having behavioral outbursts can cause. The demands parents feel, right, that teachers place on them, time constraints, due to just the number of things heaped on teachers now, and coronavirus stressors, right? We could do a whole talk about that, but I don't even know what to say about the fact that teachers are expected to do all this teaching online with their children and other demands. It's an unbelievable burden, and I'm hoping that we're going to be able to work collaboratively as a society to help solve some of these problems. So these are some of my communication pearls. So some things that I have found work for me and may work for you. So setting up your communication rules and boundaries early in the school year. I do this with my parents. So a parent that sends me an email that's got 10 paragraphs will receive an email reply that's 1 sentence. And this will help correct that tendency to not get to the point or to be too verbose or to substitute an email with what should perhaps be a phone call or an office visit, right? So setting up your rules and sticking to them. When you present concerns or share observations, don't judge, right? So I see Sally likes playing by herself versus Sally never socializes with other children. If you reserve judgment, you are less likely to get defensiveness on the part of the parent. And this is something I do as well. When sharing a problem about a child, always share a strength. That's something that I find works beautifully because no one just wants to hear the negative, right? And for disruptive behaviors, it's very helpful. Oh, all right, hang on everyone, because now is the time that I have to announce the code so that you can get the magic code, so you can get credit for watching this. So we're at the 50-minute mark, the 50 mark. So I have to read you a script. Bear with me. Thank you for participating in this webinar. To obtain a certificate of completion, you must fill out the form at the certificate of completion link indicated on the flyer for this training. Please write down this code as it will be required to receive the certificate. Ready? DAR 091001. Again, the code is DAR 091001. Now, that was all caps, the DAR. I don't know if that matters, but if you have any issues, I'm sure you can just contact the Card Center and they're always helpful. Okay, let's keep going. I was on disruptive behaviors. Communicate the strategies you're using as an attempt to say, this is what I'm trying to do, and get parents to share, obviously, what works for them at home. I find that to be a very helpful strategy. I facilitate that conversation with parents all the time. Know when in-person communication is needed. Caveat, right, with COVID is what it is here with that. It may not be possible, but at least it can be visual in addition to auditory. Offer specific resources when appropriate. That's super helpful to parents. Denial can be on the part of parents and teachers. So I wanted to point that out because I've had some times where the parent had more of a concern than the teacher. And the teacher just felt such a love or joy for this particular child that they felt by pointing out some of the problems was somehow negative or insulting. And really, it's all done in the spirit of helping that child. When tempers flare, do your best, of course, to prevent escalation of conflict. Take a breath, count to 3. And sometimes the best response is no response, right? I've had situations like that myself in the office where I'm presented with an impossible question and sometimes there's just no answer. So using empathetic listening, mindfulness, objectivity, those principles can really help. Emerging evidence and promising leads. This is a slide you can go back to later if you like, but for those 2 links at the top are some of the latest on genetic research for those of you interested. Throughout the country, there's something called the Autism Treatment Networks, and there are university programs and centers of excellence specializing in ASD, such as Johns Hopkins and Children's Hospital Philadelphia. There are other promising areas of research are postmortem brain tissue banks, where individuals have donated or offered to donate their brain upon being deceased for further research. Epigenetic phenomenon, that refers to the interaction between genes and environment. This is another super promising area of research. Microbiome, that's probiotics and all those things. People are looking into the gut flora and how that affects our neurodevelopment. And an area called pharmacogenetics, looking at the pharmacology of how you metabolize different psychotropic medications. There continues to be a push towards earlier diagnosis, which leads to earlier intervention, which leads to better outcomes, right? Cannabis is a hot topic, and CBD oil, it's an unknown. We don't know. We just don't. Unknown if ASD is going to be improved or worsened. It is being studied. There are some big trials. There's a couple going on in New York, a big one through the VA for children with ASD who are children of vets, looking at different types of cannabis use to improve behavioral symptoms. There are certain apps, video games, virtual reality, all these things have been used to teach social skills as well as augment medication effects. And then something I call the sibling effect, right? You'll see kids in your classes, and I see patients in my practice where they've grown up with the sibling on the autism spectrum. Then they become sort of, I call them ASD ambassadors themselves, right? Well, they'll befriend or help a kid in their own class, a peer perhaps, who's on the spectrum, or just be more understanding. So, and that's something that I think is a positive thing, obviously. ASD resolved, can it happen? It can. So in some, the ASD diagnosis will change. Some studies have ranged from as low as 18 to as high as 37% of children losing their autism diagnosis by the age of 4. When children do lose the diagnosis, we do know that intervention and supports are still needed for a variety of things. Those kids most capable of overcoming and perhaps no longer meeting criteria for autism are those who have a higher IQ to start with, better language ability, better adaptive behavior skills, and who have received intensive early treatment. Some of the common replacement diagnoses, so sometimes I say the ASD goes down here, but something else comes up here, and we've seen ADHD, OCD, generalized anxiety, depression, bipolar disorder, learning disabilities, some of the more common diagnoses. Why do kids lose their diagnosis? Sometimes it's legit. They have had what we call an optimal outcome, and symptoms have resolved. The social communication deficits aren't there. They're just not present. And they no longer have any of the restricted and repetitive behaviors and interests, or just to such a tiny degree. So these kids are being studied more and more. We know it happens. I can't give you a figure on how common it is, but it does occur. I'm going to spend these last few minutes, I don't want to bore you. I just want to give you historical context because I think it's so helpful. And I also think it's really interesting. So the history of autism is a really checkered past. And autism started out as being completely blamed on mothers, right? It was Connor, who was considered the father of autism, who felt mothers were responsible, cold mothers, he called them refrigerator mothers. Bruno Bettelheim, another important early researcher, also blamed mothers, and the title of his work was The Empty Fortress. Obviously, you can catch the metaphor there. That's an ugly past. Then it was really, Lovaas was key in the 60s. He was one of the first to promote behavioral treatment and looking at autism more as a behavioral condition, and then it can be improved. Crazy to think. There was a time people didn't think it could be helped at all. And then in the early 60s, Bernard Rimland, some of you may know about him through the Autism Research Institute. He's also the father of a child with autism. He started delving more into some of the psychological and neurobiological foundations of autism. Parent advocates, that started early. So Clara Park was one of the first. She wrote a book called The Siege in the early 60s. It's a fascinating read. I suggest it. And then she did a follow-up, which was kind of depressing. Written in 1991. It was about her adult daughter who didn't have such a great outcome. Now, not all the stuff is good, right? In the 90s, it was all about the MMR and thimerosal and the number of vaccines you get. And Jenny McCarthy going on Oprah and saying that she studied Google and vaccines gave her child autism, as well as Safe Minds, another big group. And Robert Kennedy Jr. is still promoting some of this anti-vaccine momentum. I'm not going to get into it, and good, I don't have time. Don't want to be controversial, but the studies do not support that vaccines cause autism. Vaccines cause vaccine injury in certain situations. And it can be a variety of things that occur, but it's not a primary cause of autism. One of the bigger proponents of it, Andrew Wakefield, completely lost his medical license in 2010. Rimland, I mentioned earlier, father of a kid on the autism spectrum who was bringing up the psychological and neurobiological issues. He is a brilliant guy. He brought a lot to the field, but I think he went a little bit off the deep end on biomedical protocols and biomedical interventions. Some of the theories he promoted and got started through his institute have never had sufficient evidence-based science to back them up. And so these theories about nutritional deficiencies, vaccines, toxic exposures, that stuff it's not based in science yet. It's more genetics, neurobiology and neuroscience, where we really look to the true underpinnings of autism. Just a little bit quickly about inclusion, neurodiversity, and advocacy. So, it wasn't until the 70s, right, that the Education for Handicapped Children Act came into being, and all kids with Downs, kids with intellectual impairments, kids on the spectrum were even welcomed into the schools. The TEACH program, where parents are co-therapists out of North Carolina, Eric Schopler, a very famous model, started actually before that in the earlier 70s. And it's very interesting, to know that it wasn't until 1980, so that was DSM version 3, that infantile autistic disorder, which was included for the first time. So where were all these individuals prior to that? Most likely lumped in with schizophrenia. And a really beautiful movie about this is called Wretches and Jabberers, about two men in their 50s who were actually institutionalized for most of their life, and actually were missed autism diagnoses. Beautiful movie. So the 1990 idea includes autism as a separate eligibility. It was in 94 that we went from infantile autistic disorder to autism, PDD, NOS, and Asperger's. And now, as you are all experts and know, in DSM-5, we got rid of all of that, and it's ASD. I want to bring out one other really important point. This 2006, Ari Neiman is one of the leaders of this neurodiversity movement. Temple Grandin also is certainly a part of that. So these are individuals super high functioning on the spectrum, can speak for themselves, and are trying to create a better appreciation and understanding first person of their needs and extrapolating to maybe what other people need who are on the autism spectrum disorder. Even including the concept of, instead of ASD, autism spectrum disorder, ASC, autism spectrum condition, where these individuals are actually really high functioning and blending in with the mainstream. They just have their quirks. Couple more slides. Bear with me. This is my favorite person in the history of autism. And she's just, I think, never got her due. Lorna Wing, there's a nice link to a YouTube video of hers before, but she was using the concept of the spectrum way before anybody else was. She was the first to translate Hans Asperger's work into English, and the first, as I said, to see autism as a spectrum disorder. Also mother of a daughter with severe autism. Interestingly, right, I also mentioned Bernard Rimland, one of the important members of the field, parent of a child with autism. And she was also one of the first to point out about how autism can affect individuals of all ages and all abilities. I love her quote, "Nature never draws a line without smudging it." That's that blurriness of that end of the spectrum where it's sort of blending in with neurotypical individuals. Final thoughts. Okay. So teachers and physicians, we're buds. We work as a team. We have a lot of shared experiences and burdens. And two of the big ones, well, four of the big ones being unreasonable expectations of what we can do. I do have a magic wand that I keep in my classroom, in my office, and maybe you want to keep one in your classroom. And sometimes in a moment for levity, I bring it out because people are looking for that magic bullet, that magic pill, that magic wand. And that leads to unrealistic expectations, right? Time constraints. There's never enough hours in the day to do all you have to do and all we have to do. And we all have long-term relationships, right? You're with kids for a year. Some of the kids I've seen, I have kids that have been with me 15 years, a few 18 years. And so these long-term relationships are something that we share. And I think we also understand as teachers and physicians the importance of collaboration, right? Now, it needs to be efficient. It's not collaboration when someone says, well, I want you to call my speech therapist, my OT, my physical therapist, the teacher. I mean, it can't be done. So trying to find ways to make collaboration effective with time. And I think this might be a pandemic silver lining, that everybody is just on the Zoom calls and on the FaceTime and on multiple calls at once, you know, multiple individuals on a call. I think that's a really good thing. And I don't think that's going to go away. Being empathetic, being non-judgmental. I mean, you know, it's something to aspire to, right? It can be difficult, but it can be helpful in our professional lives and personal lives. And we need to be allies in helping the family, right? Sometimes parents come in, they're throwing that teacher right under the bus. And sometimes I'm sure they go to the teacher and they're throwing the doctor under the bus. So the more we can ally together to help meet the needs of the family and the child, the better. There are unique challenges, of course, and serving this particular community of kids on the spectrum. And it has to do, once again, with that heterogeneity, right? There's so much variability in the assets and the deficits that we're dealing with a wide range of individuals. The advocacy community of parents, moms in particular, of kids on the spectrum, they're fierce, and they can be a force to be reckoned with for good and sometimes for not so good. Stress and burnout from these severe cases is high, right? We know what it's like sometimes, some of us, to deal with a really severely impaired child, and especially for a teacher who has that kid all day long, that can be difficult. And the difficulties coronavirus has for these kids who can't always mask, can't cover their nose or won't cover their nose, who use their mouths, who bite, who don't always control their secretions. This is a huge challenge. I don't know what the full answer is to that. I have part of an answer, but I do feel teachers need to be treated almost like nurses in their protection and what they should be given to protect themselves in the classroom. Okay, that's enough said, I guess, on that. Different, not less, right? Autism acceptance. That's what we're going for. In general, what an amazing place the world would be if we didn't use labels as a way to put children down or demean, but to help with acceptance. These are some resources from my slides where you can get more information. This is the CARD contact info. I can't sing their praises enough. They're an amazing organization. I've always reached out to them, and I know they've done so much for the community. So thanks for joining me. I hope you've learned something new today, even if you take one useful fact away. That's helpful. Be safe and take care.